welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
First, we're going to have Brian Bloesser, who is a PGY2 critical care resident at University Health in San Antonio, Texas, and he'll be presenting the Journal Club on evaluation of Diltiazem dosing strategies in the management of atrial fibrillation in the emergency department.
To get started with some learning objectives, at the end of the presentation, I hope you all be able to describe the management of atrial fibrillation with rapid ventricular response, or RVR, summarize commonly used agents for acute rate control of atrial fibrillation used in the emergency department, and evaluate a new retrospective study on dosing strategies of Diltiazem in atrial fibrillation management. To start off, atrial fibrillation is a supraventricular tachyarrhythmia, and it is the most common sustained arrhythmia out in the population. It's commonly described as a chaotic, irregular rhythm, and patients will often come in complaining of chest palpitations, a racing heartbeat, or fatigue as some common presenting symptoms there. Atrial fibrillation has a huge impact on our healthcare system. Back in 2010, there was an estimated prevalence of atrial fibrillation of 5.2 million in the US. This is projected to increase to over 12 million by 2030. So the prevalence and impact of atrial fibrillation is on the rise. Atrial fibrillation is associated with an annual individual healthcare cost of around $63,000, which notably is about $30,000 higher compared to an individual without atrial fibrillation. There are roughly 600,000 emergency department visits due to atrial fibrillation annually, which results in the statistic there, 450,000 hospitalizations annually as well. So atrial fibrillation has a huge impact on patients and their well-being, as well as on our healthcare system at large, especially in the emergency department. Our guidelines provide two different long-term management strategies for atrial fibrillation, both rate control and rhythm control. Both of these control strategies receive Category 1 recommendations in the guidelines, largely based on several randomized controlled trials like AFFIRM from 2002 or EST-AFNET from 2020 that showed really no huge differences. However, the guidelines do cite preferences in certain patients. So rate control tends to be preferred in patients who are older, generally, patients who have a longer duration of atrial fibrillation, and those presenting with a lower symptom burden, while patients who tend to be younger, have a shorter duration of atrial fibrillation or shorter duration of the disease there, a larger symptom burden, or patients with a larger amount of left ventricular dysfunction or a lower left ventricular ejection fraction tend to be favored for rhythm control compared to rate control. So what is atrial fibrillation with rapid ventricular response, or AFib with RVR? It is defined as atrial fibrillation seen on EKG with a measured heart rate of 110 beats per minute, where the number of electrical currents getting passed from the atrium to the ventricle are exceeding the heart rate there of 110 beats per minute, leading to that rapid heart rate and associated with worse symptoms compared to just standard AFib. AFib with RVR can lead to the development of pretty severe cardiomyopathy, and it can also result in hemodynamic instability, largely presenting as hypotension, which is why we want to achieve rapid heart rate control in this particular disease state and presentation. For the acute rate control of atrial fibrillation, our guidelines provide us this algorithm here, where we first have to assess if our patient is hemodynamically stable or not. If our patient is hemodynamically stable, which typically they'll be hypotensive, they recommend to proceed with direct current cardioversion as the first line recommendation. If the patient is hemodynamically stable, you need to assess their left ventricular ejection fraction and if they have decompensated heart failure or not. If they do not have heart failure, you're able to proceed with some of our pharmacologic rate control agents, commonly beta blockers or our non-dihydropyridine calcium channel blockers like verapamil or Diltiazem. If the patient does have heart failure or decompensated heart failure and pretty severe left ventricular dysfunction, they recommend to go ahead and proceed with amiodarone to provide that initial control in that acute rate RVR period. To look at a few of our select agents here that are commonly used in the emergency department, for acute rate control in the AFib with RVR setting. I selected diltiazem and metoprolol tartrate as two of the most common ones that I've seen in my practice personally. So diltiazem is a non-dihydropyridine calcium channel blocker, which given as an initial bolus of 0.25 milligrams per kilogram and can be followed by a repeat bolus 15 minutes later of 0.35 milligrams per kilogram if needed. Typically, this diltiazem bolus is followed by a continuous IV infusion of diltiazem, titrated to response of that rate control target there, and can be used for a maximum of 24 hours due to the risk of active metabolite accumulation. The IV has a fairly quick onset for diltiazem within 3 minutes, while the oral immediate release formulation also has a fairly quick onset as well, with 30 minutes to 1 hour being the onset for the oral IR diltiazem. They have pretty similar half-lives until you get to the ER formulation, which would not be used for this indication particularly. And then diltiazem is associated with some adverse effects, including hypotension and bradycardia most commonly. And then it is very important to avoid your non-dihydropyridine calcium channel blockers, including diltiazem, in patients with reduced ejection fraction, as they is associated with harm in those patients and kind of precipitating a decompensated heart failure event. Another commonly used rate control agent in the ER for AFib with RVR is metoprolol tartrate. This is one of our beta-1 selective beta blockers that it comes as an IV formulation. You can dose it from 2.5 to 5 milligrams as an IV bolus over 2 minutes, and it can be repeated up to 3 times within 15 minutes to achieve that acute rate control. Again, metoprolol has a fairly quick onset, both IV and oral, and a half-life of about 3 to 4 hours. And the IV formulation itself is particularly associated with adverse events, including hypotension and bradycardia. Today, we will be focusing more on diltiazem for the acute rate control of RVR for the remainder of the presentation. One study from Hargrove and colleagues in 2021, it was a single-center retrospective chart review study, and it was titled The Rate Control in Atrial Fibrillation, Calcium Channel Blockers versus Beta Blockers. So they included adults who were 18 or older, treated with IV diltiazem or IV metoprolol for atrial fibrillation with rapid ventricular response, which they defined as a heart rate over 120 beats per minute in the emergency department. They had 32 patients included in the IV diltiazem group, with 19 patients included in the IV metoprolol group. Their primary outcome was sustained rate control, which they defined as a heart rate of less than 100 beats per minute for 3 hours after the initial attainment of rate control. And there was no difference in the primary outcome here between diltiazem or metoprolol here in terms of sustaining rate control there. There was notably a faster time to rate control in the diltiazem group, with 15 minutes compared to 30 minutes in the metoprolol group, which was statistically significant. And notably, there were also no differences in safety outcomes like hypotension or bradycardia there. For this trial, there were no differences in the rates of sustained rate control at 3 hours with IV diltiazem compared to IV metoprolol. However, there was faster attainment of rate control in the IV diltiazem group, kind of adding to or contributing to the body of literature suggesting that diltiazem may be able to attain faster rate control and have a similar sustained response to beta blockers. One trial looking at the use of a hybrid IV to oral diltiazem dosing strategy, similar to the study we'll dive into deeper today, is written by Hall and colleagues and published in 2024. This was the comparative safety and efficacy of a hybrid IV and oral diltiazem protocol for acute rate control in the ED. They set out to compare the efficacy and safety of their hybrid IV to oral regimen compared to the standard IV bolus followed by IV infusion regimen. They included adult patients in the emergency department who received any IV diltiazem and split it into 2 groups with that IV diltiazem followed by the continuous infusion with 53 patients there, compared to the IV diltiazem bolus followed by oral administration. Notably, for their hybrid IV to oral administration group here, they did follow a protocol of 60 milligrams oral every 6 hours after the initial IV bolus there. Their primary outcome was the achievement of rate control, with no significant differences there between the hybrid IV to oral group and the IV continuous infusion group there. There was no significant difference in rates of hypotension. However, the IV continuous infusion formulation and strategy was associated with nearly 5 times the incidence of hypotension compared to the hybrid IV to oral regimen. However, again, this was not statistically significant. And there were no differences in the rates of bradycardia either between the two dosing strategies. For this trial, it looks like the hybrid IV bolus followed by oral therapy really showed no differences in either efficacy or safety compared to the standard IV bolus followed by continuous IV infusion, which kind of again adds to the body of literature suggesting that the use of oral diltiazem for management of acute rate control in atrial fibrillation with RVR in the emergency department may be a reasonable strategy, similar efficacy and safety profile to that standard IV infusion that we are all very familiar with. That brings us to the study we'll be diving deeper in today. So today we're going to be looking at the evaluation of diltiazem dosing strategies in the management of atrial fibrillation in the emergency department by Agee and colleagues published early last month in November. They set out to compare the incidence of treatment failure between diltiazem oral immediate release tablets and continuous IV infusion of diltiazem following that initial loading dose in patients with AFib with RVR. This was a single-center retrospective cohort study evaluating the patients from July 1st, 2020 through June 30th, 2022. They included patients who were 18 or older with EKG showing AFib with RVR with a heart rate of 110 beats per minute, who received IV diltiazem IV bolus, followed by either the immediate release tablet or the continuous IV infusion within 4 hours. They excluded patients who were hemodynamic on presentation, which again was primarily that hypotensive presentation, excluded pregnant patients, and also excluded any patients who received any other rate controlling medication, antiarrhythmic, or direct current cardioversion prior to that initial IV diltiazem bolus. So for the intervention and comparator in this trial, they had the initial IV bolus of diltiazem for about 1 to 2 doses, followed by either treatment with that immediate release IR oral diltiazem with 85 patients in that treatment group, and then or the treatment by the continuous IV infusion with about 86 patients in that treatment group. For the baseline characteristics between the two groups, they were pretty well matched. I did want to point out this was a particularly older population above the age of 65 on average in both groups, with a large amount of patients with a history of atrial fibrillation, nearly half in each group, who were on outpatient rate control medications about 30% of the time, presenting with that initial heart rate about 145 to 150 between the two groups there. Their initial bolus dose was significantly different between the two groups on a milligram basis. However, when comparing the milligram per kilogram dosing, there was no significant difference there, just to point that out as well. For their outcomes, their primary outcome was a composite outcome of treatment failure here at the top. Their composite outcome consisted of the additional 3 outcomes seen on the latter half of this table, with no significant difference in their composite outcome of treatment failure. However, we did see the requirement of an additional bolus within 4 hours, more commonly in the oral immediate release diltiazem group, with about 32% of the patients requiring that additional bolus there. However, in the trial, or in the paper itself, they did not discuss whether this was a second or third bolus. As I discussed prior in the presentation here, with the typical dosing strategies of diltiazem, you could get that 0.25 mg per kg dose, the bolus, and then 15 minutes later, if needed, you could get another 0.35 milligram per kilogram bolus dose as part of the standard dosing here, which these potentially could have been second doses here in that additional bolus group for that oral agent group first. Numerically, more patients did require switching to a new drug within 4 hours in the immediate release oral diltiazem group compared to that continuous IV infusion. And then also really wanted to point out here that at that 4-hour mark, there were the lower incidence of a sustained heart rate above 110 beats per minute in that oral group compared to that continuous IV infusion group. This could be due to several factors, but it is a potential signal that the oral group here was able to sustain a longer term rate control compared to that IV infusion group, which we'll discuss more when we get to limitations of the trial later. For additional outcomes here, they looked at hospital length of stay with no significant difference here. And then they also looked at the disposition from the emergency department. There was a significantly higher rate of discharge from the emergency department in that immediate release oral diltiazem group compared to that continuous IV infusion, which is unsurprising. Obviously, our patients can go home on oral tablets. They're not able to go home really on a continuous IV infusion of diltiazem. So this oral dosing regimen may potentially have contributed to easing discharge there or facilitating discharge, although the study isn't necessarily powered to detect this difference particularly. And then there were also a higher rate of admissions to the hospital floor in the IV infusion group there as well. For safety outcomes, there were no significant differences in their composite outcome of clinically significant hypotension, with an incidence of 12% and 8% in each group there. Their composite outcome here was consisted of the latter half of the table here. So vasopressor use, mean arterial pressure less than 65 millimeters of mercury, or systolic blood pressure less than 90. And again, there was no significant difference between the two dosing regimens here on any of those safety outcomes. For some strengths of this trial, it was a real-world pragmatic evaluation of this dosing strategy in a functioning, busy ER that is seeing tons of patients. And so it is pretty practical and seems like this is an applicable and very doable strategy to implement in many ERs across the country. And this does support the use of an oral dosing strategy to potentially decrease atrial fibrillation admissions, although we'll discuss that more with limitations here. For some limitations of this study, they had a retrospective study design, so it's associated with all of the standard limitations there with our retrospective studies requiring the accuracy and thoroughness of the charting to happen in the moment to be able to accurately and appropriately conduct a retrospective study here. They did not include any dosing information in the study for the oral regimen here, including the milligram dose, frequency, and then also how soon they got the oral dose following that initial IV bolus. There was no information on the long-term sustained rate control past that 4-hour mark, and they had a very low sample size. An additional limitation here when looking at the admission rates and discharge or dispo from the ER, they did not include any reasons for the admission. Obviously, as I'm sure you're all aware, there are numerous reasons for patients with atrial fibrillation to go into atrial fibrillation with RVR. And if the inciting event is not addressed during their stay in the ER, they may need to be admitted to the hospital, the floor, or the ICU to potentially manage that inciting event, which kind of limits the applicability of potential reduction in discharge here due to not knowing if these patients were admitted just for a one-off atrial fibrillation event or if they were, potentially septic and going into AFib with RVR due to the sepsis there. For the overall conclusion from the trial here, it does appear that oral immediate release diltiazem was associated with similar rates of treatment failure and few admissions from the ER compared to a continuous IV infusion. However, like I pointed out with the limitations, especially with that dispo from the ER at admission rates, it is fairly unclear out the causes of the admissions being cited there. The key takeaway here for me was really that utilizing an oral diltiazem dosing strategy for the treatment of AFib with RVR in the emergency department could potentially help reduce the burden on the hospital and hospital admissions from the emergency department for AFib with RVR directly, while potentially helping reduce the costs and associated burden of atrial fibrillation on the healthcare system itself. And I do think it is, with both this study and the Hall study I discussed prior, a reasonable strategy to utilize in the emergency department setting to, if patients are able to take oral tablets and swallow tablets appropriately, I think it's reasonable to use this dosing strategy rather than committing a patient to an IV infusion and admission there to either the floor or ICU potentially. Yeah, with that, I will open it up to any questions y'all may have for me. Thank you for taking the time to listen to me.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.